Good morning. My topic is polycythemia. During this half an hour, I will try to discuss what is polycythemia, what are the causes of polycythemia, what should be the approach to the diagnosis, and what are the available management options. We will first see what is polycythemia. Polycythemia is an absolute increase in the total red cell mass. As you can see in this diagram, when compared to the normal person, there is a definite absolute increase in the red cell mass in polycythemia. So this manifests as a raised hemoglobin and or hematocrit. Hematocrit is better in identifying patients with raised red cell mass than hemoglobin. Remember that when we are dealing with patients with polycythemia, we take decisions mainly based on the hematocrit rather than on the hemoglobin. So whenever a patient presents with a report of raised hemoglobin or hematocrit, the first thing we have to do is to repeat and confirm it before going into further investigations. So this is to exclude any pre-analytical errors. And preferably we should repeat with adequate hydration and non-tunica sample. Persistently high hematocrit, more than 52% in males and more than 48% in females, requires further evaluation according to the BCSH guidelines. Then a word about true versus apparent polycythemia. When you have raised hemoglobin or hematocrit, if the red cell mass is raised, you call it true polycythemia. If the red cell mass is not actually raised, but your hemoglobin and hematocrit is raised, you call it apparent polycythemia. This occurs due to a reduction in the plasma volume. As you can see in this diagram, this is the normal person. This is the person with apparent polycythemia. There is a reduction in the plasma volume. Therefore, there is relative increase in the red cell mass. Therefore, you will get a report with high hemoglobin and hematocrit. So what are the causes for apparent polycythemia? The patient might have hypertension, obesity, excessive alcohol, diuretic therapy, burns, dehydration, and smoking. Remember, smoking can cause reduction in plasma volume and apparent polycythemia, and also smoking can cause increase in the red cell mass, an absolute increase in the red cell mass and true polycythemia. So smoking can cause both. You have to remember that. Then psychological stress, which is called stress polycythemia. It's a apparent polycythemia. There are long-standing state of low plasma volume, which is seen commonly in active, hardworking, anxious, middle-aged men. And this is called stress polycythemia. Even though the books say like this, detecting true versus apparent polycythemia requires chromium label studies. So there we have practical difficulty in diagnosing true versus apparent polycythemia. So we have to carefully analyze the history, examination, all the relevant findings, and then decide whether we are dealing with the apparent or true polycythemia. So you have to remember that. And on the other hand, it's not clear whether apparent polycythemia increase the rate of thrombosis. One of the main worries in polycythemia is whether the patient can get a thrombosis due to increased red cell mass and hyperviscosity. However, the hematocrit more than 54 in apparent polycythemia is likely to be associated with thrombotic risk. Therefore, maintaining hematocrit less than 54% is recommended in apparent polycythemia patients. Now we will have a look at the causes of true polycythemia. For true polycythemia, there are primary causes and secondary causes. I will explain what they are. In primary polycythemia, the abnormalities in erythropoiesis itself. There is an inherent problem in erythropoiesis, and the body is producing more. There is overactive erythropoiesis due to genetic mutations in the erythropoietic pathway. Erythropoiesis in primary polycythemia is autonomous and does not depend on erythropoietin. It's proliferating by its own. Erythropoietin has no say. Right? Remember that. Then in secondary polycythemia, this occurs due to abnormal and excessive erythropoietin secretion, which occurs due to various pathological causes. Right? Secondary polycythemia is due to abnormal erythropoietin, whereas in primary polycythemia, it's completely different and it does not depend on erythropoietin. Primary polycythemia can be either due to polycythemia vera, which is the common cause, and there are rare causes which are called primary familial and congenital polycythemia. These are autosomal dominant and erythropoiesis is intrinsically overactive. There can be mutations either in the erythropoietin receptor or in the related molecules. There is no splenomegaly, normal WBC and platelets when compared to polycythemia vera. Then we will come to polycythemia vera. Polycythemia vera occurs due to a unique acquired mutation in the myeloid stem cells of the patients. There is hyperplasia of all three lineages, erythroid, granulocytic, and megakaryocytic. This is a myeloproliferative neoplasm. This occurs due to the famous JAK2 mutation. So, what is JAK2 mutation? There is a kinase called Janus-associated kinase 2. If you look at this diagram, this is the erythropoietin receptor in green, and this is erythropoietin. When the receptor is bind to the when erythropoietin is bind to the receptor, there will be downstream signaling for the cell to proliferate. This is what happens in normal situation, and this is where JAK2 acts. When there is adequate proliferation, the JAK2 inhibits the proliferation, stops it. When the JAK2 is mutated, this is the commonest JAK2 mutation, V617F mutation. When the JAK2 is mutated, JAK2 enzyme loses its ability to control the erythropoietin receptor. Then the receptor will continue to send downstream signals and the cells will continue to proliferate. So there is no control. This is what happens in polycythemia vera. Right? So this is what happens due to JAK2 mutation. Okay? So about 95% of patients with polycythemia vera are positive for JAK2 V617F mutation. Right? There are other mutations as well. JAK2 exon 12 mutation is seen around 1 to 3% of patients. This is seen in younger patients and have a more isolated erythrocytosis with less frequent thrombocytosis and leukocytosis. Therefore, if you are dealing with a young person who is JAK2 negative, who is having only erythrocytosis, and you want to exclude primary polycythemia, vera, you may have to go ahead with JAK2 exon 12 mutation. Okay. So if the patient is JAK2 positive, now here what we mean by JAK2 positive means JAK2 V617F mutation. If the patient is JAK2 positive, it's easy to diagnose polycythemia vera, presence of the mutation and high hematocrit, 52% in men and 48% in women, and which is persistent, will be diagnostic of polycythemia vera. Then JAK2 negative polycythemias, this is a rare entity. As you know, 95% are JAK2 V617F mutation positive, and around 1 to 3% are exon 12 mutation positive. Then the remaining small percentage comes under JAK2 negative polycythemia. Then there's a set of criteria which you have to meet. A1 to A3 plus 1A criteria or 2B criteria are required for diagnosis. These include presence of splenomegaly, bone marrow histology, presence of thrombocytosis and neutrophilia more than these cutoff points. So there's a set of criteria to meet, but this is a rare entity. The polycythemia vera, median age is between 55 to 60 years, but the incidence increases with age, but this can occur at any age, even rarely in childhood. There is a slight male predominance, 1.2 to 1. So how do polycythemia vera patients present? It can be an incidental detection on full blood count with high hemoglobin and hematocrit, or plethora detected by a clinician or somebody. Or a splenomegaly might be detected, and when you further investigate, you will diagnose polycythemia vera. Splenomegaly affects around 30 to 40% of polycythemia vera. Then thrombotic events, neurological manifestations, skin manifestations, hearing or visual problems, hypertension. These are the different ways of presentation. Thrombotic complications are the most common and serious complication of polycythemia vera. In untreated patients, there is a greatly increased risk of thrombosis. These can be arterial, venous, or microvascular. They might present with myocardial infarction to cardiology unit, or strokes and TIA to neurology unit, then sudden onset blindness or scotoma, and they will present to eye unit, or they might present to general surgeon or vascular surgeon with dysentery or limb ischemia. Then you will diagnose and detect polycythemia vera. Venous thrombosis at unusual sites is strongly correlated with the presence of JAK2 V617F mutation. And superficial thrombophlebitis is also a feature of polycythemia vera. Conventional DVT and pulmonary emboli are also seen in these patients. So anybody coming with this sort of thrombosis, your differential diagnosis has to include polycythemia vera. Then microvascular occlusions, erythromelalgia, where there is intense redness, pain, and warmth of the extremities, which might persist or can be episodic. That is called erythromelalgia. That is a feature of polycythemia vera. They can also present with headaches, drowsiness, insomnia, amnesia, chorea, and even depression. These are due to poor circulation due to hyperviscosity. And they can also present to ENT units with tinnitus, vertigo. Right? So these are the different ways of presentation. Then can present to dermatology units with pruritus. This is a severe characteristically aquagenic pruritus which can occur in about 25% of polycythemia vera patients. And rosacea-like facial skin changes, which is a redness in the face with visible blood vessels. Right? Brown discoloration of the skin and rarely sweet syndrome, which is another skin manifestation of bone marrow disorders. Polycythemia vera patients can transform to acute myeloid leukemia. Right? The risk is 1 to 3% without cytoreductive therapy. Risk with hydroxycarbamide therapy is approximately 20% at 20 years. Okay? Then progression to myelofibrosis occurs in around 10 to 20% of cases at 15 years after diagnosis. Right? So these are the two complications. These will not come within 1 or 2 years. Long-standing polycythemia vera can end up with AML or myelofibrosis. Right? This will not happen in each and every patient. There are various other secondary genetic modifications and long-term changes needs to happen for the polycythemia vera patients to transform to these two entities. Okay. So that is polycythemia vera in brief. Now we will have a look at the causes of secondary polycythemia. Secondary polycythemia, as you know, is depending on the abnormal erythropoietin secretion. So this abnormal erythropoietin secretion can be either due to tissue hypoxia, where there is compensatory increase in the erythropoietin, or there can be some source in the body where there is inappropriate or exogenous erythropoietin secretion. Right? So we will first have a look at the causes for tissue hypoxia causing compensatory increase in the erythropoietin. Chronic lung disease or chronic hypoxia. Chronic obstructive pulmonary disease, obstructive sleep apnea, especially in obese people, hypoventilation due to muscle weakness or paralysis can result in chronic hypoxia. This this is a compensatory polycythemia. This compensatory polycythemia increases the oxygen carrying capacity, but that also increases blood viscosity and push the patient towards thrombotic side. So that's why we are worried. Therefore, hematocrit should be maintained less than 55% with a target of 50%. Right? You have to individually tailor the preferable level for each patient depending on the lung problem in each and every patient. Right? Nobody can give a definite cutoff because you have to balance the compensation versus thrombotic risk. If you try to reduce the hematocrit too much, then the patient will lose the compensatory effect and patient will be more hypoxic. If you try to keep this more than 55%, the patient's hypoxic problem will be sorted, but the patient will end up having a thrombosis. Therefore, the doctors who are working in the respiratory units have to know this, that you must not try and do vivisection in each and every patient who has polycythemia due to chronic hypoxia. Each patient has to be considered individually and a level, preferable level has to be decided. Right? Cyanotic heart disease is another cause of compensatory polycythemia. In cyanotic heart disease, I think you would have seen enough patients, their hematocrits are very high, can run up to 80%, right? So this is also kind of compensatory polycythemia. Now these patients, hematocrit need to be brought down if there are certain symptoms. You don't try to reduce hematocrit by vivisecting everybody because patients with cyanotic heart disease are hemodynamically not very well compensated. So if you try to reduce the blood volume suddenly, then they might have cardiac complications. And on the other hand, if you try to reduce the hematocrit, they might get more hypoxic and then there can be a vicious circle. So when you're thinking of bringing the hematocrit down in cyanotic heart disease, all these factors have to be considered. So what the guidelines say is to try and reduce hematocrit if there is recurrent hemoptysis, marked fatigue, and deteriorating exercise tolerance. And these are the given indications to reduce hematocrit in patients with cyanotic heart disease. The doctors working in cardiology units have to remember these points. Okay? There is no target hematocrit level. Like in the respiratory patients where there is a range given, here there is no such limit or range. It's always individual. Okay? Then a word about heavy smoking. Heavy smokers. What is actually meant by heavy smoking is at least one packet of cigarette per day for 5 to 10 years at least. Right? Various I went through the literature. Various places are saying various things. Some say 25 cigarettes a day for 25 years, and there isn't a clear definition of who is a heavy smoker, right? I think respiratory doctors might know better than me whether there is a clear definition for a heavy smoker. Anyway, heavy smokers have chronically raised carbon monoxide levels 3 to 20%. Binding of this carbon dioxide to hemoglobin, displacing oxygen leads to formation of carboxyhemoglobin. So these heavy smokers have carboxyhemoglobin in their blood. So this carboxyhemoglobin, once the percentage in the blood goes up, then the oxygen delivery capacity is reduced because there is certain percentage of hemoglobin which can't bind oxygen. So there is tissue hypoxia, which lead to erythropoietin-driven polycythemia. Okay? But in these patients, again, there is no hematocrit cutoff for venesections. Venesections need to be considered if there is a clear thrombotic history or if high risk, like there is a strong family history with thrombosis or some high risk factor for thrombosis. Then you think of bringing the venesection down, bring the hematocrit down with venesection, right? So this also you have to take each and every patient individually, assess and decide on the venesections. Then two fairly uncommon causes, high affinity hemoglobins, which have increased affinity to oxygen. This leads to erythropoietin-driven polycythemia because they don't deliver oxygen to the tissues. They have high affinity. They try to keep the oxygen with them. On the tissue level, there is a relative hypoxia. But in these patients, hyperviscosity is rare as a symptom, even though their hematocrit is high. and there is no known cardiovascular mobility. Therefore, no hematocrit target level to be maintained. In hereditary methemoglobinemia, which is even rarer cause, there is oxidation of the heme iron, which converts it to ferric form. Right? Ferrous is converted to ferric form permanently. So then that hemoglobin is called methemoglobin, which has increased affinity for oxygen. So this gives rise to tissue hypoxia and cyanosis and subsequent erythropoietin-driven polycythemia. Right? So these are the causes of hypoxia-driven erythropoietin increase and polycythemia. Then inappropriate or exogenous erythropoietin. As you know, erythropoietin is produced mainly in the kidney fibroblasts, and small amount is produced in the perisinusoidal cells of the liver. So inappropriate means the normal sites are producing excessive amounts, abnormal amounts. That is called inappropriate erythropoietin secretion. Exogenous erythropoietin means there is some other source in the body, some abnormal source, producing erythropoietin or erythropoietin-like substance. Right? Renal disease, renal tumors, both malignant and benign, hydronephrosis, polycystic kidney, renal artery stenosis, where there is local renal hypoxia and increased erythropoietin. And in post-transplant patients, up to 20 to 30% can have excessive erythropoietin and polycythemia. Right? Then liver disease, hepatocellular carcinoma, cirrhosis and hepatitis, certain cases, not all of them, few cases, can produce excessive erythropoietin. Endocrine diseases like parathyroid tumors, pheochromocytoma, Cushing's syndrome. Okay. Then cerebella and other hemangiomas, meningiomas, which are producing erythropoietin or erythropoietin-like substances, and large uterine fibromyomatas. All these can cause excessive erythropoietin and polycythemia. Okay. In drugs, treatment with erythropoietin, too much erythropoietin can also cause polycythemia. Androgens, anabolic steroids, recreational drugs. So these latter ones, if there is a young male, especially males with polycythemia where you can't find any cause, you may have to think of recreational drugs and things like that, whether that is the cause for polycythemia. Right? So these are the causes for secondary polycythemia. Then a word about idiopathic erythrocytosis. What is it? Right? There is true polycythemia, increased red cell mass, but you can't find a cause for the polycythemia. Then we put that patient into the idiopathic group. Can't find a cause. This only small proportion of patients fall into this group nowadays because we extensively investigate and find some cause for most of the polycythemia. So these can be either due to rare inherited causes where we do not have facilities to test for them, or they will go on and develop polycythemia vera later. Maybe the initial stage, right? So these patients are usually treated with low dose aspirin unless it's contraindicated, and the hematocrit target to be maintained is 45%. Now we have gone through briefly all the possible causes for polycythemia. Then we will see what should be our approach to the diagnosis of a patient with high hematocrit. Now, having known the causes, I hope I didn't confuse you all. Having known the causes, now it will be easier to have a better approach to assess a patient with high hematocrit. You have to first confirm it by repeating the test and then go ahead with clinical history and examination, where you have to get the drug history, smoking, alcohol consumption, history of heart, lung, kidney, liver disease, and any hyperviscosity symptoms, previous thrombotic episodes, and in your examination, whether the patient is obese and whether this is something like sleep apnea syndrome, and is there splenomegaly, signs of non-secondary causes you have to look for in your examination, skin features of polycythemia vera. Then you will come to certain differential diagnosis. The long list you can cut down to some extent by history and examination, then decide on the investigations. Okay. So full blood count and especially blood film will show some features of polycythemia vera if they are present. Neutrophilia, thrombocytosis, and platelet anisocytosis, where there is a significant size variation. And you have to go ahead with renal and liver function tests, pulse oximetry. And if you suspect sleep apnea, you have to refer for sleep studies or refer to a respiratory physician. Serum ferritin, if it's low levels are common in polycythemia vera because iron is consumed to produce more red cells. Sometimes iron deficiency can give a misleadingly low hematocrit, iron deficient polycythemia. Okay. Then serum erythropoietin if exogenous secretion is suspected. Ultrasound scan abdomen to look for the spleen size, renal liver pathology, and JAK2 mutation. Bone marrow assessment, which will show the characteristic features of polycythemia vera, including pan-myelosis and the megakaryocytic morphology, and so on. Okay. Then what are the management options? So our management aims at two things. If it's polycythemia vera, we have to control the disease and also we have to reduce the thrombotic risk. Okay. In other causes of polycythemia, main aim of a hematologist is to avoid thrombotic complications, but the particular cause has to be dealt with. Right? So in polycythemia vera, you have to risk stratify according to the age and the presence or absence of thrombotic episodes, low risk and high risk categories, and then decide on the management. Available management options are vivisections with a target of equal or less than 45% of hematocrit, right? That is the target. So there are slightly different targets in secondary causes. You have to remember these. Then cytoreductive therapy, hydroxycarbamide is the first thing we use. Antiplatelets, aspirin therapy is essential. And now we have JAK2 inhibitors, which is one is the commonly used one is ruxolitinib. There are definite indications for the use of ruxolitinib in polycythemia vera patients. All the patients will not get it. So these are the available treatment options. With these available treatment options, you can control the disease and the thrombotic risk in polycythemia vera patients. So at the bottom are the two BCSH recent guidelines, if you like to go through. Guideline for the diagnosis and management of polycythemia vera and guideline for the management of specific situations in polycythemia vera. If you are interested in more details, please go through them. So, few take-home messages. Every patient with polycythemia do not need a JAK2 mutation study. So we see some doctors doing JAK2 for every high hematocrit. It's not indicated. evaluate the patient, and if it's required, then do it, because it's around 8,000 rupees. So your decision has to be clear. Then negative JAK2 mutation does not always exclude polycythemia vera, right? Apparent polycythemia is an important entity in the differential diagnosis. Okay? And venesection is the mainstay in management, irrespective of the cause of polycythemia, and the cutoffs are different. Right? Okay. So thank you very much for your listening.
Thank you, Dr. Gunawardena. You can ask questions if you have. We have about 1 or 2 minutes. Anyone has questions, you're very welcome to ask.